Welcome back friends, and I am Dr. Abhijit Dam, and I am the President of the National Association of Palliative Care for Ayush and Integrative Medicine. And today I am here to discuss issues of constipation and how it is relevant in palliative care. So, believe me, once your bowel shuts down, it shuts down your whole body, right. Your brain gets clouded, you can't think properly, your appetite goes down, you feel nauseous. It is all very, very shitty. In short, your quality of life goes down. And especially if you are a bedridden patient, if you are in pain, you can't get up and passing motions becomes a big problem. Believe me, there is nothing as worse as constipation. So, constipation is a big issue in palliative care, and dealing with the south end of a horse, dealing with constipation is also sort of a social stigma. People do not want to talk about it, they do not want to discuss about it, and the caregivers, for the caregivers, cleaning up the feces and cleaning up the urine of a patient was one of the greatest factors, most worrisome factors for the caregivers, right, which put them at a great sort of disadvantage. So, what exactly is constipation? Constipation is the passage of small hard stools or the painful passage of stools which results in lot of straining, or stools being passed at prolonged intervals. Now, what exactly is the interval? Every person has their own routine of passing stools, right. Some would pass stools once in 3 days. For them, passing once in 3 days is normal. So, that is fine, or some may pass 3 stools in 1 day. So, that is also fine. So, any disturbance from your established routine which is seen as abnormal and is causing symptoms would be considered as constipation. Now, food takes 24 to 48 hours to travel. Right. Once I eat an apple, by the time the residue of the apple would come out of with my feces, it would take approximately 24 to 48 hours, out of which 90% of the time is spent in the large intestine, that is the colon, right. So, for the movement of the large intestine, so many factors are, there are so many hormonal interplays are needed, like motilin and an intact autonomic nervous system. So, for example, in diabetics, in long standing diabetics where there is a disturbance of the autonomic nervous system, they would have constipation. In the elderly, where the neuronal motor complex gets degenerated, right. So, for them, for the elderly, constipation would be a problem, where there is less motilin, right, or if you are taking certain drugs, like if a patient is taking morphine for pain relief. So, morphine is known to cause severe constipation. So, there are so many agents which would actually contribute to your constipation. Simple lack of exercise, and if you are bedridden continuously, so that is another factor which can cause constipation. So, amongst the symptoms prevalence in palliative care, constipation stands a big third. Almost 70% of the patients complain of constipation at some point of time or other. So, the etiology of constipation could be malignancy, the cancer per se. So, if you see, suppose now if this is the intestine, this is the lumen of the intestine, right. Now, if there is a tumor growth here which is obstructing, this is a tumor growth here which is obstructing the lumen. So, this can cause constipation, or if there is a external pressure on the intestine from outside which is compressing the intestine, this external pressure could be due to external tumors or whatever. It could be due to ascites, which is filling up of the abdomen with fluid. So, if there is an external pressure on the intestine, this will squeeze the intestine, and that can cause constipation. Or if the intestinal motility, it is a segmental movement like this, which pushes the stools forward. If the intestinal motility is reduced because of the causes which I mentioned earlier, then too there would be constipation. Then medications, as I said, morphine is a beautiful example, right, and other cholinergic medications like antispasmodics. Many have antispasmodics like drotaverine, Drotin tablets and Buscopan and so on and so forth. These antispasmodics would also cause constipation. Concurrent disease like hypercalcemia, when the level of calcium in your blood goes up, hypercalcemia can contribute to constipation. If you have hypothyroidism, your thyroid hormones are less, then that would cause constipation. So, constipation has multiple etiologies. So, as I said, malignancy can cause obstruction by tumor in the wall, external compression by the tumor, where there is neuronal damage, the motility of the intestine is affected, hypercalcemia I did mention. Secondary effects, suppose the patient is having a very low intake, very poor intake of food, very low intake of fluid, very low intake of roughage in the diet, like fiber based diet, right. And as I said, medications like antidepressants, most of the tricyclic antidepressants can cause constipation. But the most important is unfamiliar toilet arrangements. Suppose you go to a hospital, it is a crowded room and the toilet is very dirty. Can you use it? You try to push it off, or you are traveling in a bus, in a crowded bus. So, and for maybe 2 days, so you would try to put off going to the washroom, right. So, this unfamiliar toilet arrangements are a major cause of constipation in hospitals and in hospices. Everybody wants to use the washroom of their own house because they are used to it. It is a familiar arrangement, and I know I respect my privacy, my family members respect my privacy. So, I am used to it. So, it is fine with me, but once you go to somebody else's house, so you are not familiar with the toilet arrangements out there, and then maybe you will that is a secondary sort of constipation which you can get. So, unfamiliar toilet arrangements and lack of privacy is a big factor for constipation. Now, as you see here, this photograph I had taken from a hospice in Pune. This is an Indian style toilet, but if you see the grab rails, sitting down is easy, but once you use the toilet and then you have to get up, because the patients are so weak, or in obese patients they need help to get up, and so this grab rails, so this hand rails, by this they grab hold of it and then they manage to get up. So, these type of arrangements are important. See again this grab rails in the western type of commode. So, these are very important and very simple to simple to put in place. I had talked about medication. So, many medications can cause constipation like opioids, phenothiazines, tricyclic antidepressants, anti-Parkinsonian drugs, antacids, especially aluminum based antacids, right. Opioids, almost 87% of the patients taking morphine will have constipation. So, it becomes mandatory for a physician who is prescribing morphine, he should also be prescribing a laxative along with it, a prokinetic type of laxative, because laxatives are of so many kinds. So, you have to prescribe a special type of laxative which increases the forward movement of the intestines. So, other medications which can cause constipations are diuretics, anticonvulsants, iron supplementation. This is a very common cause, iron supplementation, right, antihypertensives, etc., etc. Concurrent diseases, I talked about diabetes, hypothyroidism, hernia, hemorrhoids, neuropathy, various types of neuropathies, dementia, Parkinsonism's disease, right. And chronic constipation can result in so many problems like hemorrhoids, rectal prolapse, fecal impaction. Fecal impaction is very, very difficult. One of my first patients in whom I had to do a manual removal of feces was in Rishikesh. I used to volunteer in a hospice in Rishikesh, where I used to teach the nursing team out there how to do home care. And I remember during one of those visits, there was a bedridden patient and he was constipated for almost 7 days. So, I decided to do a manual evacuation of the rectum or manual removal of feces. So, this is a technique where there is a loss of dignity for the patient and it is socially not acceptable at all. So, we had to explain to the patient for quite some time. We afforded some degree of privacy and then we arranged old newspapers below the buttocks of the patient, and then I used lignocaine ointment, which is a local anesthetic ointment. I put on a pair of gloves gently. I was very gentle with the patient. I explained it to him what I was doing and why I was doing it, and the poor gentleman agreed. And then I gently, after putting the local anesthetic in his anus and slightly inside, I waited for 5 minutes and then gently I put my finger inside, and those retained feces are just like small hard stones. They become so hard. It is just like opening a bottle of champagne. Unless you take off the cork, the champagne can't come out. So, once you uncork it, the whole of the champagne flows out. So, similar thing out here. So, I had to break those particles of feces and drag them out, and then the rest of the stools started coming out, and it was such a relief for the patient. But for me, the smell made me gag, and I knew that my team was watching me. As a team leader, I had to hide my expression, and luckily I was wearing a mask, and you should keep a window open and you should keep the fan on, so that the smells move out. But believe me, it is such a gratifying and a humbling technique, and once you see the patient's smile at the end of the procedure, and that is your greatest reward. So, how to assess? You can do a digital rectal examination, you can do an abdominal X-ray, in which you can divide the abdominal X-ray into various quadrants and all. I won't go into the details of this. So, and then you got to take a proper history of constipation. When was your last bowel motion? What is the frequency of a bowel motion? And what are the characteristics of the stool, whether it is hard, impacted, painful stools, whether you have pain during defecation, whether blood comes out, whether there is associated nausea and vomiting, so on and so forth. So, this is, I talked about the flat plate, an X-ray of the abdomen, you divided it into 4 quadrants and so on and so forth. So, coming to the treatments, prophylaxis is always the best. So, ask the patient to take plenty of water, slight movement if possible. If movement is not possible, then gentle abdominal massage, starting from the right lower quadrant, coming up to the right upper quadrant, and then going transverse, and then going down the left side. So, follow the motion, follow the peristaltic movement of the large gut. Reversing potentially reversible factors, or like hypothyroidism is treatable, or hypercalcemia is treatable, so on and so forth. Most important is creating a favorable environment. So, maintaining adequate privacy, giving adequate time for the patient, giving adequate encouragement to the patient. Diet of bananas, prunes, plenty of coffee, beer actually has glycerin, which helps in defecation. Abdominal massage I talked about, and then laxatives. So, laxatives, drug therapy would come to the last, and so there are various groups of therapy, right. So, it could be a stool softener, it could be a stimulant. So, basically if you are using morphine type of drugs and that is causing constipation, then you need a stimulant. If there are hard stools always, maybe you would require a stool softener. So, this is an exhaustive list, right from Isabgol. This is usually available everywhere, almost in every small town, even in grocery shops, you call it Isabgol ka bhusi. So, you just take 1 or 2 large tablespoons full of Isabgol and soak it in water, or give it with hot milk in the evenings. So, that is good for people who are mobile. And then you have so many other groups of drugs. I will not go into the details now. Prokinetic agents, you can use domperidone, like I use domperidone quite frequently, metoclopramide you can use, erythromycin you can use, right, so on and so forth. So, friends, this was all about constipation, and I hope that you have got a broad idea about constipation and how it can adversely affect the quality of life of patients who require palliative care, and what are the social and other stigmas associated with constipation. Thank you.